Welcome to this module on radiological anatomy of the head and neck region. This module includes normal and abnormal radiological images pertaining to the head and neck region. Let us begin with an X-ray of the skull. Here we have a lateral view of a normal skull. Note the bony features seen on this X-ray. We start with the bony cranial vault seen here. One can see suture lines such as this. One notes structures in the base of the skull, such as the sella turcica seen here, the seat for the pituitary gland. Structures in the orbit, the air sinuses such as seen here, and other facial bony structures. One also can observe the superior end of the cervical spine. The striking feature seen in a lateral skull X-ray is overlapping structures. This is confusing and sometimes makes clinical interpretation of these X-rays difficult. Here we have an X-ray of the skull seen in an AP view. Note again several overlapping bony structures. We note here the roof of the orbit seen on the right side of the skull and a similar bony structure seen on the left side of the skull. Superior to this we see the frontal air sinus on both sides. One can see the nasal cavity with the midline nasal septum, and on either side of the nasal cavity are the maxillary air sinuses. One also sees the oral structures such as the teeth and the mandible. Due to the fact that there are several overlapping bony structures seen on the standard AP and lateral views of the X-ray of the skull, several special views have been created. Let us look at a few examples of some of these special views. Here we have an open mouth view or an AP anteroposterior odontoid view. This X-ray is taken through the open mouth to visualize the odontoid process of the C2 vertebra, seen here. One can clinically diagnose abnormalities associated with the odontoid, such as fractures. The two structures seen here on either side of the odontoid process are parts of the first vertebra or the atlas. Here we have another special view called the occipitofrontal view or the head tilted view. In this particular instance, the various air sinuses are clearly visible, such as the frontal and the maxillary air sinus. A third view is called the base of skull view, and this particular X-ray brings out some of the structures in the base of the skull, which are not normally visualized in a standard AP or lateral film. It is not important for you to remember details of these special views at this time. The take-home message is simply look in the correct place for the correct thing. Here's our first clinical case. We are presented with a 28-year-old male patient who has 4 months history of visual disturbances and headache. A lateral skull X-ray was taken, which is shown here. Note in this particular X-ray an enlarged sella turcica. This is an example of acromegaly, which is caused due to pituitary adenoma, a tumor in the pituitary gland. On X-ray, the enlarged pituitary gland shows an expansile sella turcica. The visual disturbances caused by this tumor are due to its anatomical location very close to the optic chiasma. Our next case is of an 8-month-old child who was involved in a motor vehicle accident and sustained injury to his forehead. A lateral X-ray of the skull is shown here. Note a radiolucent line running across the anterior part of the skull. This is an example of a skull fracture. Fracture lines running across the skull are different than standard suture lines in their shape, size, and location. An AP view of the same child shows the fracture line running across here. Let us look at some more examples of skull fractures. This is a case of non-accidental skull fracture where there are multiple fracture lines crossing the suture lines, and we note fractures running across here, as well as here, as well as here, and several other minor fracture lines. This is a case of a battered baby syndrome. Another example is seen here. This is called a blowout fracture of the orbit. Unlike the normal side seen here where there is a smooth contour of the bone, here we find an irregularity and the arrows point out the fracture location. Here we have another fracture of the skull called a tripod fracture where there are three fracture lines running across at the three locations around the zygoma or the zygomatic bone of the cheek. Here we have another example of a very common fracture running through the nasal bone called a nasal fracture. We have another clinical case here of a 32-year-old male patient who was involved in a motor vehicle accident and sustained injury to his face. Here we have his X-ray, which shows multiple fractures around the mandible and the maxilla. Over here the maxillary bone is fractured, and over here the mandibular bone is fractured with a fracture line running across. In such type of complicated fractures, other imaging modalities such as CT scans and particularly 3D reconstructions from CT scans are very helpful, such as this. Here we have an example of a mandibular fracture which has 3D reconstructions to clearly depict the altered anatomy. Let us go through several CT scans from a superior to an inferior direction. Again, note that all CT scans are represented as if viewed from below, from the foot end of the patient. In this particular CT scan, this is the anterior end of the patient, this is the posterior end of the patient, this is the right side of the patient, and this is the left side of the patient. This is taken through a level that is at the level of the orbits. We see some ethmoid air cells. We see the sphenoid air sinus just posterior to that. We have the optic nerve running to the eyeballs on both sides, the lateral rectus muscle, and the medial rectus muscle. Going somewhat inferiorly to this, we have several structures at this level, such as the maxillary air sinus, the opening or the ostium of the maxillary sinus into the nasal cavity, the middle concha or middle terminates in the nasal cavity, the sphenoid air sinus posteriorly, the sphenoid bone on the side, the mastoid air cells posteriorly, the internal carotid arteries lying by the side of the sphenoid air sinus, and just posterior to that are the internal acoustic meatus, and posteriorly is the cerebellum. Going further inferiorly, we have several other structures. In the midline, we have the nasal septum, which at this level is made up with the vomer bone. We have the maxillary air sinus on the lateral sides, the inferior concha or the turbinates opening into the nasal cavity, the nasopharynx lying posteriorly, with its lateral pharyngeal recess and the opening of the eustachian tube. The coronoid process from the mandible are seen lying laterally on either side. The internal carotid artery in the carotid canal is seen here, and lying out posteriorly and laterally are the mastoid air cells. Going further inferiorly to the level of the foramen magnum, we find the incisor teeth anteriorly and the foramen magnum posteriorly. Other structures seen at this level include the styloid process, seen on both the right and left sides, the mastoid process, seen posterior to that, and the mandibular ramus, seen on the right side and also on the left side over here. This is the level of the oropharynx, which is seen here, with its retropharyngeal space. We also see structures such as the parotid gland out in the soft tissue. We now come to the level of the hyoid bone. This is the level of the C4 vertebra, with the vertebral body seen here and the lamina seen posteriorly. Here we see the piriform sinus, the submandibular gland, one of the salivary glands, and the carotid sheath with its contents, which include the internal jugular vein, the vagus nerve, and the internal carotid artery. These structures are overlapped by the sternocleidomastoid muscle. Here we have another clinical case of a 32-year-old female patient who had a history of progressive unilateral proptosis. That means one eyeball becoming more prominent or larger and being pushed forward. She also complained of diplopia, which is double vision, and diminished visual acuity. An MRI was done for this patient, and here are two images, a T1 and a T2 weighted image, that shows the clinical condition in this patient. We find a large swelling like tumorous condition here behind the eyeball on the right side. The same swelling is seen here, a large tumor behind the eyeball. The tumor is almost the size of an eyeball, giving the impression that there are two eyeballs on this side. This is a clinical condition called an orbital cavernous hemangioma. This is a benign condition where there is collection of large blood vessels in an abnormal location. Let us now focus on the cervical spine. Here we have an X-ray of a normal cervical spine, and this is an AP or anteroposterior view. One sees the cervical vertebra here, along with their subparts, such as the pedicles on the right side and the pedicles on the left side. One sees the midline cervical spine over here. One can look for abnormalities such as cervical ribs, which would be seen in this location on an AP view of the cervical spine. Here we have a lateral view of a normal cervical spine. Note that all 7 cervical vertebrae should be visible before one can make any reasonable comment. Here we have the first cervical vertebra, the second, the third, the fourth, the fifth, the sixth, and the seventh. All 7 cervical vertebrae are visible. It is helpful to make a comment on the prevertebral soft tissue seen here in this area, which is less dark than the air which is seen anterior to this structure or this line. Typically, the prevertebral soft tissue should be about 4 to 5 millimeters in size above the C4 vertebral body, which is seen here. Below the C4 vertebral body, the maximum width of the prevertebral soft tissue is approximately 1 vertebral body in width. Here we have a sagittal reconstruction of an MRI of a patient, and note the excellent soft tissue visualization as opposed to plain X-rays. One can note the cervical vertebral bodies and the spinal cord, as well as the cerebrospinal fluid around the spinal cord in quite good detail. When we talk about a lateral view of the cervical spine, there are several imaginary lines that are drawn which give us an indication of the clinical condition or stability of the spine. The first line goes through the anterior parts of the vertebral body. The second line goes through the posterior part of the vertebral body, and any disruption here is indicative of severe injury. A third line goes through the spinolaminar area, called the spinolaminar line, at the junction of the spinous process and lamina. And a fourth one goes through the spinous processes of the C7. These four lines together provide us information about the stability of the cervical spine following injuries. When we are faced with a clinical condition where we need to make an assessment of the cervical spine from a stability point of view, it is very important that we have all 7 cervical vertebrae visualized. In the X-ray seen here, it is difficult to make any comment on the cervical vertebra because only 6 are visible. The first one, second, third, fourth, fifth, and sixth. In fact, this patient had a second X-ray that showed all 7 vertebrae, and a diagnosis of a C6 over C7 subluxation was made, which is a major injury. Remember, all 7 need to be visualized. Thank you. This brings us to the end of this module on radiological anatomy of the head and neck region.